Imagine walking into a hospital in one of the most advanced IT superpowers on Earth.
Right.
You have like a simple cut on your hand, or maybe just a persistent fever. You're looking for basic care.
Just something routine.
Exactly. But the moment you cross that threshold, you are stepping into a system that is mathematically engineered to push your family into permanent poverty.
It sounds completely dystopian, I know.
It really does. But today, we're looking at a stack of documents that claim this isn't some tragic accident of underdevelopment. According to our sources, it's actually a flawlessly executed business model.
Yeah, we are dissecting a very specific, very alarming paradox today, centered entirely on India.
Right.
I mean, we all know the country's global reputation, right? There's an economic titan that's this massive hub of technological innovation and a total pharmaceutical powerhouse.
Oh, totally.
Yet the research and the policy briefs we're unpacking for this deep dive, they present this sort of shadow reality. They argue that beneath all that gleaming surface, the country is functioning as a massive engine for generating poverty.
And it's driven by this catastrophic intersection of failing healthcare infrastructure, predatory finance, and spreading superbugs.
Exactly.
And the data they present is just arresting. I mean, one of the most staggering figures we'll be looking at claims that up to 94% of families face functional bankruptcy if just one family member requires hospitalization.
Wow. Yeah, 94%. That statistic alone completely reframes how we need to think about medical care.
I mean, it really does.
It's no longer just a health crisis at that point. It's an economic trap.
Right, and to understand how this trap is built and sprung, we are drawing on a really dense collection of materials for you today.
We have policy briefs and operational frameworks from Dr. Kadiyali Srivatsa. He's a veteran physician who's been deeply involved in these issues for decades.
We're also analyzing data from the GRAM project. That's the global research on antimicrobial resistance.
Plus, we have mortality projections from the Institute for Health Metrics and Evaluation. And some incredibly detailed financial forensics mapping the recent invasion of private equity into the healthcare sector.
Yeah, that financial forensics part is wild. So our mission for this deep dive is to map the exact mechanics of this crisis for you. We want to understand the how and the why.
Right. Like, how does the government's historical failure to invest in public health care leave this massive vacuum for Wall Street to fill?
And how does the biological terror of antimicrobial resistance, or AMR, act as this force multiplier for wealth extraction?
And perhaps most crucially, we're going to explore a brilliantly simple offline AI technology. It's designed to bypass this entire system.
But then we'll examine why the authors claim it is being actively obstructed by institutional gatekeepers.
Yeah, that part is particularly frustrating to read. Before we dive into the financial architecture, we really need to establish the analytical lens for this conversation.
That's a great point. I want to be crystal clear with you, the listener, about our role here.
The documents we are synthesizing contain severe systemic critiques. I mean, the authors take direct aim at government policies spanning multiple administrations.
Right. They criticize politicians for relying on private hospitals and private medical schools to fill the gaps in public health.
They aggressively critique the medical industrial complex and the bureaucratic agencies overseeing it.
So our goal is not to endorse these viewpoints. We aren't taking a political stance or attacking any specific administration or corporation.
No, not at all. We are just here to impartially map out the arguments and the data presented in these specific source documents.
Exactly. We want to lay out the mechanics of what these researchers claim is happening so that you can understand the underlying dynamics of their argument.
So, synthesizing this data requires us to start at the foundation of the author's argument. The capital flows.
Always follow the money, right?
Always. The generation of poverty described in these texts begins with a massive systemic shift away from public healthcare investment.
Right. The authors argue that politicians basically expected private hospitals and private medical schools to organically solve the healthcare access problem.
Which is essentially outsourcing a fundamental state responsibility.
And nature abhors a vacuum, right? And so does capital. The sources detail how global private equity, or PE, rushed in to fill this space.
Yeah, we are looking at a $15.5 billion capital influx into Indian healthcare over just the past 5 years.
Billion with a B. And these aren't like small regional investors. The documents specifically name massive global players: Blackstone, KKR, Temasek.
The scale of that capital completely changes the DNA of the institutions it touches.
Yeah, how so? Like, what happens when they buy in?
Well, when Blackstone takes a 73% ownership stake in care hospitals, or an 80 to 85% stake in Kim's Kerala.
Or when Temasek injects $2 billion into Manipal hospitals.
Right, exactly. The fundamental objective of those buildings shifts. The authors argue that under PE ownership, a hospital ceases to be a community health asset.
And transforms into an EBITDA-driven profit machine.
Exactly.
For those who might not know, EBITDA being earnings before interest, taxes, depreciation, and amortization. Basically, the ultimate corporate scorecard.
It's pure profit measurement.
But what I really wanted to dig into is the mechanics of how they extract that profit. Because it's not just a matter of, raising the price of a bandage by 10%.
Oh, no. It's much more structural than that. The sources outline what they call the PE playbook.
Yeah, and the first maneuver they describe is the sale-leaseback. I was reading this section, and let me see if I have the analogy right. It feels a bit like corporate asset stripping.
The mechanics are remarkably similar, actually, and the downstream effects on patient care are profound.
Okay, so let's say a private equity firm buys a hospital, maybe for 500 crore rupees.
Right. They now own the business, the staff contracts, the equipment, and the physical real estate.
But almost immediately, they split the company, they take the physical building and the land, and they sell it to a separate real estate holding company.
A company that, conveniently, the PE firm also owns or controls.
Exactly. You have the structure mapped out perfectly.
The PE firm effectively moves the most valuable tangible asset, the real estate, off the hospital's books and into a protected corporate vehicle.
And then this new real estate holding company turns around and charges the hospital exorbitant rent to operate in the very building it owned yesterday.
Yeah. The text uses a hypothetical figure, suggesting a sudden 50 crore rupee annual rent burden.
So the hospital, which might have been running a modest sustainable surplus before, is instantly plunged into a massive manufactured operating loss.
And the implications of that newly manufactured debt are where the poverty generation really begins.
Because the underlying cost of delivering medical care hasn't actually changed.
Right. The MRI machines aren't newer, the doctors aren't inherently more skilled, the nurses aren't getting massive raises.
The only thing that has changed is that the hospital now has this crushing real estate obligation to its parent company.
So the hospital administrators look at this massive new hole in their balance sheet, and the PE owners dictate that patient billing must be drastically increased to cover it.
Wow, so the patients walking through the doors aren't paying for better health care. They are unwittingly servicing the debt of a complex corporate real estate transaction.
Exactly, which forces the hospital into the second phase of the playbook outlined in the documents, margin optimization.
Okay, margin optimization, what does that look like on the ground?
Well, in an EBITDA-driven system, the traditional triage model, where you treat the sickest people first, is quietly replaced by financial triage.
So patients are categorized not by the severity of their illness, but by their margin contribution.
Yes, the texts actually call it patient filtering, and it is incredibly clinical.
They describe how low-margin patients, like people coming in with routine fevers, basic checkups, preventive care needs, are actively discouraged from utilizing the facility.
The mechanisms of that discouragement are subtle, but very effective.
Like what?
Like, the hospital limits the number of available appointments for general physicians. They deliberately understaff the outpatient departments, creating agonizingly long wait times.
Oh, wow. So they just make it miserable to be there.
Yeah, and they track doctors' metrics and penalize them for spending too much time on non-procedural consultations.
The institutional goal is literally to make the experience so frictionless for the wealthy and so arduous for the general public that the low-margin patients simply give up and go elsewhere.
Exactly. Leaving the hospital floors entirely optimized for the high-margin patients.
The people who need robotic surgeries, complex oncology treatments, multi-organ transplants.
Right. The sources describe these patients receiving concierge-level service.
Because the entire infrastructure of the building, from the valet parking to the VIP suites to the fast-track diagnostics, is redesigned to capture, process, and bill these high-yield cases as efficiently as possible.
Which brings us directly to the third step, aggressive upselling.
Upselling in a hospital, it sounds so wrong.
It does. But when the hospital is structurally dependent on high-margin procedures to pay its manufactured rent, the medical professionals themselves become instruments of revenue generation.
The text provides a deeply illustrative anecdote from a practicing cardiologist that maps this exact transition.
That story really crystallized the concept for me.
Yeah, this cardiologist explains that before the buyout, they would see maybe 30 patients a day. And based entirely on genuine medical necessity, they might recommend 2 or 3 angioplasties a month.
Right. It was a clinical decision based purely on the patient's heart health.
But then the private equity takeover occurs, and the administration completely restructures the compensation model.
The fixed salary is reduced, and the bulk of the doctor's income is tied to procedure volume incentives.
So the administration gives the cardiology department a monthly target of 25 angioplasty procedure.
25, up from 2 or 3. And if the doctors fail to hit that quota, their bonuses evaporate, their performance reviews tank, and their department risks losing funding or facing staffing cuts.
The ethical compromise forced upon the medical staff is just immense.
The sources argue that in this environment, doctors are systematically coerced by financial imperatives to recommend invasive, expensive, and sometimes medically unnecessary procedures.
I mean, imagine a patient comes in with mild chest pain that could be managed with medication and lifestyle changes. But because the department is 3 angioplasties short of its monthly quota,
The patient is rushed to the cath lab.
it's treating human health like a high-pressure sales floor.
And this brings us back to that terrifying statistic we mentioned at the start. 94% of families face bankruptcy following a single hospitalization.
Right. When you understand the PE playbook, the manufactured rent, the margin filtering, the quota-driven upselling, that number ceases to be a mystery.
It is simply the logical output of the system.
And the authors emphasize that this burden is almost entirely borne by the individual. They cite data showing that 63% of healthcare spending in India is out of pocket.
Millions of people are paying cash directly to these optimized profit machines without the buffer of comprehensive national insurance or robust public hospitals to fall back on.
And the corporatization doesn't even stop at the hospital doors. The documents introduce a concept that expands this wealth extraction model even further: vertical integration.
Yeah, they use the example of PB Fintech, the parent company of the insurance aggregator Policy Bazaar.
Okay, tell me about this, because this part was wild.
So the financial filings cited in the text show PB Fintech raising $218 million specifically to launch its own chain of hospitals with a target of 25 to 30 facilities by 2030.
Think about the mechanics of that for a second. An insurance company is building its own hospitals.
Right.
It's like a casino owning the slot machines, the ATM in the lobby, and the company that issues your credit card. The authors point out the total collapse of checks and balances in this scenario.
The conflict of interest is structural. I mean, the company selling you the health insurance policy will now own the hospital diagnosing your illness.
And prescribing your treatment and billing for the services.
Exactly. And crucially, they are the exact same corporate entity that will approve or deny your insurance claim to pay for it.
They literally control the premium, the procedure, and the payout. It is a perfectly closed loop.
A perfectly closed loop designed for extraction.
But as I was reading through these financial teardowns, a massive question kept looming in the background for me.
What's that?
This entire private equity model, the robotic surgeries, the ICU upselling, the 50,000 rupee procedures, it relies on one foundational assumption.
Right. It assumes that when they cut you open, you will eventually heal.
Exactly. It assumes that 20th century medicine actually works.
The entire financial architecture is built on the efficacy of antibiotics.
If they perform an unnecessary angioplasty or a highly profitable joint replacement, they need to know that the inevitable post-surgical infections can be managed with a cheap, reliable pill or IV drip.
But the sources pivot hard here, introducing a biological catalyst that shatters that assumption entirely.
The authors argue that we are rapidly crossing the threshold into the post-antibiotic era, driven by the silent explosion of antimicrobial resistance, or AMR.
And the text makes a fascinating, if terrifying, argument. AMR isn't just a clinical failure where drugs stop working. It is the ultimate poverty multiplier.
The intersection of biology and economics here is the absolute core of the author's thesis. The data they draw from the Graham Project and the Institute for Health Metrics and Evaluation is staggering.
They position India as the global epicenter of this specific crisis.
Let's walk through the numbers they provided, starting with the hospital environment itself, because we usually think of a hospital as a sterile sanctuary.
Right, but a multi-country study published in The Lancet, which is heavily cited in our stack, claims that an astonishing 83% of hospital patients in India are colonized by multi-drug-resistant organisms, or MDROs.
83%. And colonization means the bacteria are present on or in the patient's body, even if they aren't actively causing an infection at that exact moment.
Exactly. An 83% colonization rate implies that the hospital environment itself is entirely saturated.
The moment a patient enters the facility, the probability that they will acquire a superbug is just overwhelming.
And when those colonizations turn into active infections, the mortality data is brutal. The IHME data points to over 300,000 AMR-related deaths in India in 2019 alone.
And the text highlights one specific, just heartbreaking subset of that data. 58,000 newborns dying annually specifically from drug-resistant infections before they are even a month old.
It's horrific. That the sheer scale of the resistance forces us to ask why this specific geography is so uniquely vulnerable.
Right. The sources argue it is a perfect storm of environmental drivers, regulatory gaps, and socioeconomic realities. It goes way beyond simply prescribing too many pills in clinics.
The authors actually dedicate significant space to the environmental vectors. The first issue is the pervasive over-the-counter sale of antibiotics.
Right. People can routinely purchase broad-spectrum antibiotics without a prescription, so a daily wage earner gets a scratchy throat from a viral infection.
They can't afford to take a day off to see a doctor, so they go to the pharmacy and buy azithromycin.
And the antibiotic does absolutely nothing to the virus.
Nothing at all, but it acts as a massive evolutionary stressor on the natural bacteria living in that person's microbiome.
So the weak bacteria die, and the ones with genetic mutations that allow them to survive the drug multiply. Every unnecessary pill consumed accelerates the training of these superbugs.
Exactly. But human consumption is only a fraction of the problem. The texts point to massive industrial and agricultural leaching.
Yeah, India is one of the world's largest manufacturers of pharmaceuticals.
And the documents describe how antibiotic residues and active pharmaceutical ingredients are frequently discharged directly into waterways and soil from these manufacturing plants.
Add to that the runoff from animal husbandry. Antibiotics are heavily used in livestock and poultry farming, not just to treat sick animals, but as growth promoters and preventative measures in really crowded conditions.
So the animal waste, completely saturated with resistant bacteria and unmetabolized antibiotics, runs directly into rivers, lakes, and groundwater.
The authors argue that the environment itself has basically been transformed into a planetary-scale petri dish. The soil and the water are actively selecting for resistance.
Which brings us to the timeline the sources construct. Because they don't frame this as a distant theoretical threat.
No, they point to a very specific collapse point projected for the year 2035.
Let's explore what that actually means on the ground. When they say collapse, they aren't talking about a new pandemic. They are talking about the structural failure of everyday medicine.
The projection suggests that by 2035, resistance to frontline antibiotics could reach between 68% and nearly 100% in certain regions.
In that scenario, the fundamental risk-reward calculation of medicine just flips entirely.
Right. Routine procedures, cesarean sections, appendectomies, hip replacements. Procedures we consider entirely standard today will carry unacceptable, potentially lethal risks of infection.
Because if a surgeon opens your abdomen for a routine procedure and a stray superbug enters the wound, there's literally no drug left in the arsenal to save you.
The text also notes that complex interventions like cancer chemotherapy rely heavily on suppressing the patient's immune system.
Right, and without functioning antibiotics to act as a shield, chemotherapy basically becomes too dangerous to administer.
The medical implications are obviously catastrophic, but the authors immediately tie this back to the economic thesis.
They estimate that the collapse in healthcare capacity driven by AMR will push an additional 24 million people into extreme poverty globally.
I really want to spend some time mapping the exact anatomy of that poverty generation, because it's easy to view AMR purely as a biological failure. The drug doesn't bind to the protein, the bacteria survives, the patient dies.
But the sources argue that the period between the failure of the drug and the death of the patient is exactly where the financial extraction occurs.
So how does biology actually generate poverty?
The authors illustrate this through a cascade effect, particularly focusing on the working class. Let's trace the path of a manual laborer.
Okay.
In an era of functional antibiotics, this laborer sustains a minor cut on the job. It gets infected. They take a cheap, generic course of antibiotics for a week.
The infection clears, and they are back at work with minimal disruption to their livelihood.
Right. The economic impact is negligible. Just a minor inconvenience.
But in the post-antibiotic era, or even the current environment described by that 83% MDRO colonization stat we talked about, that cheap pill completely fails.
The local infection spreads to the bloodstream. The laborer doesn't return to the construction site. They are rushed to the emergency room and likely admitted to the intensive care unit.
Instantly, their daily wage, the sole income supporting their entire family, drops to zero.
And while the income vanishes, the expenses skyrocket exponentially.
Because the infection is resisting standard, affordable treatments, the hospital is forced to escalate.
Right. They deploy expensive, last resort reserve antibiotics. They order continuous high-end diagnostic panels to figure out exactly what strain they're fighting.
The patient requires strict isolation protocols, continuous monitoring, and really specialized nursing care.
So the hospital bill explodes precisely because the infection is untreatable.
And if this laborer has been brought to a facility owned by a private equity firm,
One that has filtered out low-margin care and optimized for high-yield, prolonged ICU stays.
the billing structure is designed to extract maximum value from every single day that patient is in the bed.
Exactly. So the family, desperate to save their breadwinner, turns to informal lending networks.
They borrow money at crushing interest rates to cover the spiraling hospital bills.
The laborer is trapped in the ICU, the debt compounds daily, and eventually, despite the massive expenditure, the superbug often wins.
The family is left without their primary earner and saddled with unpayable multi-generational debt. The authors argue that AMR serves as a mechanism that maximizes financial extraction right up until the point of mortality.
That cascade perfectly illustrates why the authors focus so heavily on specific demographics. With a healthcare system optimized for extraction and superbugs making basic care impossibly expensive, who gets crushed first?
The sources zoom in tightly on the foundational pillars of the Indian economy. The analysis points directly at the agricultural sector, manual laborers, and self-employed individuals who survive entirely on daily income.
These are populations that possess virtually zero financial buffer.
And from an epidemiological standpoint, they are completely on the front lines. The farmers and manual laborers are the ones working in the soil, dealing with the animal husbandry runoff, and exposing themselves daily to the environmental pathogens we discussed earlier.
They are literally navigating the petri dish.
Yeah. Dr. Srivatsa actually includes a really powerful anecdote from his own time as a medical student to ground these statistics in reality.
Right, he recounts living on a farm outside Bangalore decades ago. Local farmers, knowing he had medical training, would seek him out when they fell ill.
And he describes the visceral reality of seeing farmers sustain seemingly trivial injuries, a scrape from a tool, a minor laceration, that rapidly deteriorated into septicemia leading to death.
In that era, Dr. Srivatsa notes, the tragedy was purely economic.
Because the antibiotics that could have saved them existed, and they worked perfectly well, but the crushing poverty of the farmers kept those life-saving drugs out of reach. They died of poverty disguised as infection.
The authors argue that the horrifying evolution of this dynamic is that today the outcome is identical, but the underlying cause has shifted entirely.
Even if a farming family sells their assets to scrape together the money for the latest generation of antibiotics, the superbugs, strains like methicillin-resistant Staphylococcus aureus, or MRSA, will simply shrug the drugs off.
The economic inability to access care has been replaced by the absolute biological failure of the care itself.
And the socioeconomic fallout of this dual failure is quantified in the text, and it is just devastating.
The sources detail how rural families, caught between failing treatments and escalating private hospital costs, are driven to local moneylenders.
They borrow at extortionate rates, creating an inescapable debt trap. They are forced to sell their crops to middlemen at a loss just to service the interest on medical debts, ending the harvest season deeper in poverty than they began.
The documents cite data from the National Crime Records Bureau to illustrate the ultimate human cost of this trap. In 2023 alone, there were 10,786 suicides by individuals involved in the farming sector.
If you break that down, it equates to nearly 30 farmer suicides every single day. We are looking at the agrarian backbone of a nation, the people quite literally feeding the population, being treated as financially and medically disposable.
The spatial distribution of the healthcare infrastructure just reinforces this abandonment. The sources point out a really jarring geographical disparity. 70% of India's population resides in rural areas.
Yet over 90% of the private equity-backed, highly capitalized hospitals are clustered tightly within Tier 1 and Tier 2 urban centers.
Because the capital naturally flows to where the high-margin, insured patients live.
The system hasn't just failed to reach the rural foundation, it has effectively seceded from them. It's built this high-tech, high-cost fortress in the cities, leaving the rural majority entirely exposed to the rising tide of drug-resistant pathogens.
And the vulnerability extends beyond the rural farms, too. The texts highlight another massive, sociologically distinct demographic that is equally trapped, a group researchers are calling the waithood generation.
Okay, this is a critical concept in the author's analysis. It refers to millions of educated but fundamentally disenfranchised young adults.
In many cases, their families liquidated assets or took on massive debt to finance higher education, operating under the assumption that a degree was a guaranteed ticket into the modern affluent economy.
But the reality they face upon graduation is starkly different. The text suggests that many of these degrees function as effectively counterfeit credentials in a job market that demands highly specific modern skills.
Consequently, this entire generation is caught in a paralyzing socioeconomic limbo. They feel, perhaps rightfully so given their education, too qualified to return to the manual labor or agricultural work of their parents.
But they are simultaneously locked out of the lucrative tech and corporate sectors.
Right, they spend years trapped in permanent unemployment, often studying endlessly for government exams that are delayed or highly oversubscribed.
Because they have zero steady income and are aging out of their parents' financial support, this massive demographic is entirely cut off from the expensive, urban-centric private healthcare system.
They are the smartphone generation, sitting in tea stalls, consuming cheap data, hyper-aware of the medical advancements available to the wealthy.
Yet fully cognizant that they are one minor drug-resistant infection away from destroying whatever financial stability their family has left.
The authors really paint a picture of a multi-tiered systemic gridlock.
The state is not building sufficient public clinics. The private sector is geographically and financially inaccessible to 70% of the country. And the biological reality of AMR is making basic infections incredibly dangerous.
It becomes incredibly obvious that if a solution is going to work, it cannot rely on the traditional medical architecture.
Right, it can't be another hospital building, and it can't be an expensive app that requires an unlimited data plan. It has to exist completely outside the current paradigm.
And this brings us to the specific intervention detailed in the documents. Dr. Kadiyali Srivatsa's 35-year mission to deploy the Prima kiosk.
Right. The text pivots from diagnosing the systemic failure to presenting a highly specific, operationalized solution. Prima stands for Personal, Responsive, Empowering Medical Assistance.
When we talk about a kiosk, it's easy to picture a slick iPad on a stand in a modern lobby. But the business plans and technical specs provided in the sources describe something radically different.
Designed specifically for the environments we've just discussed. The hardware is built for resilience. The documents describe a physical, freestanding machine designed to be deployed in local corner stores, village pharmacies, and community centers deep in rural areas or urban slums.
Crucially, it is solar-powered to withstand erratic power grids, and it is entirely offline capable, requiring no continuous internet connection to function.
At its core, the kiosk is a delivery mechanism for an AI system called Dr. Maya AI. The texts argue that the true innovation isn't the hardware, but the clinical triage logic powering the software.
It relies on a methodology Dr. Srivatsa developed decades ago, known as the pediatric assessment triangle.
The system is designed to democratize medical diagnosis by categorizing a patient's symptoms into 4 distinct, immediately understandable color codes.
When a patient interacts with the kiosk, the AI runs an assessment and sorts their condition.
Let's break down those 4 colors, because the authors argue this logic is the key to dismantling the poverty trap.
The first category is yellow. This indicates that the symptoms are mild and self-limiting.
The AI advises that home care, rest, hydration, perhaps over-the-counter fever reducers is the appropriate response.
The sources highlight a crucial statistic here. An estimated 68% of all cases fall into this yellow category.
68%. The second color is green. This means the symptoms are moderate, and the patient should seek consultation with a physician within the next 48 hours.
It's not a panic situation, but it requires professional eyes.
The third color, blue, is directly targeted at the AMR crisis we discussed. A blue code flags a high probability of an infectious outbreak or a resistant pathogen.
It instructs the patient to isolate immediately and seek specialized testing, acting as an early warning radar for the community.
And finally, red indicates a critical medical emergency requiring immediate transport to a hospital or emergency room.
But the UI, the user interface of this system, is where it really bridges the gap. We established that the vulnerable populations are often rural and financially excluded.
The business plan explicitly targets the 760 million Indians who do not own smartphones. Building a solution for that demographic requires discarding the Silicon Valley playbook.
An app is useless without a device and a data plan. The Prima kiosk is designed as shared community infrastructure.
Furthermore, it targets the estimated 287 million illiterate adults in the country. If you can't read a diagnostic report, an AI text chatbot is completely inaccessible.
To solve this, the kiosk utilizes extensive voice guidance in regional dialects: Hindi, Tamil, Bengali, Marathi.
The interface is highly visual and icon-based. A user doesn't need to type out complex symptoms. They interact with a digital avatar, touching the areas on a human diagram where they feel pain.
And Dr. Maya speaks back to them, guiding them through the triage process verbally.
The authors argue that this combination of accessible hardware and intuitive software attacks the generation of poverty on two highly specific fronts.
The first front is the prevention of predatory billing, and this ties directly back to that yellow category.
The financial impact of the yellow category is profound. Imagine a mother in a rural village. Her child develops a high fever in the middle of the night.
In the current system, fear and a lack of reliable medical information take over. She might borrow money from the local moneylender the next morning to pay for a grueling bus ride into a Tier 1 city.
She walks into one of those private equity-owned profit machines we discussed earlier.
The hospital, operating on its margin optimization playbook, subjects the child to a battery of unnecessary diagnostic panels, maybe an overnight observation stay, and prescribes expensive, unneeded, broad-spectrum antibiotics.
The family has billed thousands of rupees for a simple viral fever that would have resolved on its own.
The Prima kiosk physically intercepts that chain reaction of wealth extraction by providing immediate, authoritative, localized reassurance that the condition is a yellow, that the child simply needs rest and hydration. The AI prevents the unnecessary journey.
It stops the family from entering the extractive machinery of the private hospital entirely. It replaces manufactured panic with actionable information.
The second front the kiosk operates on is direct economic empowerment. These machines aren't earned and operated by a massive, centralized corporation.
The business model described in the documents relies on local franchising. The kiosks are designed to be run by self-employed micro-entrepreneurs.
And the business plan specifically targets women in these communities, as well as members of that educated, unemployed waithood generation we discussed earlier.
The local operator manages the machine, assists community members who might be intimidated by the technology, and earns a small fee or commission per consultation.
The financial projections in the documents suggest that an operator could realistically generate between 30,000 to 50,000 rupees monthly in passive income.
This flips the economic dynamic. Instead of a rural family's limited capital being siphoned out of the village to pay dividends to a sovereign wealth fund in Singapore, the capital circulates locally.
The healthcare intervention simultaneously becomes an engine for local microeconomic development.
I have to admit, reading through this section of the sources, my skepticism flared up a bit. The documents present this as a near-perfect silver bullet.
Right.
The hardware is remarkably affordable. It actively stops unnecessary hospital visits and protects families from medical bankruptcy. It provides a steady income for local youth.
And with that blue code, it creates a real-time, decentralized surveillance network for tracking AMR outbreaks before they spread.
It sounds objectively phenomenal. So if this solves the exact bottlenecks we've been agonizing over for the past 40 minutes, why hasn't it been widely adopted?
That is the big question.
Why isn't there a Prima kiosk in every village square? Are the machines breaking down?
The authors anticipate that exact skepticism, and their answer forms the most cynical and alarming portion of the entire stack of documents. They argue unequivocally that the lack of adoption has absolutely nothing to do with technological failure or flawed economics.
They claim it is deliberate systemic obstruction.
Yes. The texts assert that the institutional gatekeepers, the health ministry bureaucrats, the medical boards, and the corporate healthcare executives actively and intentionally block disruptive tools like the Prima kiosk.
And they block them precisely because the tools threaten the established status quo.
The documents dive into the psychological underpinnings of this obstruction, utilizing a framework called polyvagal theory.
I found this application of neuroscience to bureaucratic behavior fascinating.
It really is. Polyvagal theory deals with how the autonomic nervous system unconsciously assesses safety and risk in the environment.
The authors apply this biological lens to high-level decision makers. The argument is that when a hospital executive or a government bureaucrat is presented with a disruptive innovation, they do not evaluate it through a prefrontal cortex lens of logic, public good, or efficiency.
Right, they don't look at a 100 rupee AI triage tool and think, oh, this will save 1 million lives.
Instead, their nervous system processes the innovation as a direct biological survival threat.
Think about what Dr. Maya AI represents to an institution built on the PE playbook. When an executive looks at a tool that successfully empowers 68% of potential patients to stay home, they see an empty hospital bed.
They see a failure to hit their monthly EBITDA targets. They see their lucrative diagnostic lab sitting idle.
They perceive a catastrophic loss of centralized control. According to the author's application of polyvagal theory, when these executives enter that defensive threat response state, they become biologically incapable of collaborative reasoning or embracing change.
Their systemic response is simply to attack, discredit, or bureaucratically smother the innovation.
To illustrate this dynamic in action, the sources draw a very sharp, revealing contrast between the obstructed Dr. Maya AI and the AI frameworks that the government is actively approving and funding.
Specifically citing systems named SAHI and BODH. The authors argue that examining the architecture of SAI and BODH reveals exactly what the establishment values.
These government-approved frameworks are designed from the ground up to serve institutions. They are enterprise-level systems built to be integrated into the existing workflows of large urban hospital chains.
They are designed to assist doctors in analyzing scans or optimizing hospital logistics, which means they keep the power, the diagnostic capability, and the financial transaction entirely locked within the traditional doctor-centric, urban-focused system.
Exactly. To benefit from SAJ, or BODH, the rural farmer still has to travel to the city, check into the expensive private hospital, and pay the massive consultation fee. The AI just makes the hospital more efficient at processing them.
By contrast, Dr. Maya AI is radically decentralized and patient-centric. It bypasses the institution entirely.
It places the power of primary triage directly into the hands of a mother in a remote village at 3 in the morning.
Institutions, whether in finance, tech, or healthcare, instinctively hate decentralization because it removes their ability to act as the toll collector.
The authors argue that healthcare providers and heavily funded tech startups build solutions almost exclusively for the urban 30%. That demographic has smartphones, reliable broadband, disposable income, and private insurance.
They are highly profitable. The remaining 70%, the farmers, the daily wage laborers, the waithood youth, are essentially invisible to the venture capital models driving health tech innovation.
Because building a rugged offline kiosk for a village doesn't yield the exponential 10x financial returns that investors demand.
The ethical conclusions the authors draw from this obstruction are profoundly disturbing. The gatekeepers, the regulatory bodies, and medical councils rarely admit they are protecting their profit margins.
Instead, they weaponize bureaucracy. They block decentralized tools under the guise of patient safety. They argue that it's too dangerous to let an AI diagnose people without years of institutional compliance studies.
But the authors force us to examine the reality of that delay. By demanding endless institutional oversight and actively blocking a 100 rupee triage tool that works right now, what is the actual result on the ground?
The authors argue that this bureaucratic stonewalling effectively condemns millions of people to death by delayed care and untreated superbugs.
It exposes a systemic, institutionalized preference for highly profitable sickness over low-margin wellness.
The grim implication of the text is that the system would rather a patient die quietly in a rural village because they couldn't afford to travel to a private hospital than allow a non-institutional, decentralized AI to teach them how to safely manage a fever at home.
The stack of sources we've reviewed today paints a comprehensive, if incredibly dark, picture of a system functioning exactly as it was designed to.
The central thesis we've unpacked is that the massive generation of extreme poverty in India is not a tragic byproduct of development. It is the mathematical result of abandoning public healthcare responsibilities to the extractive mandates of private equity.
We've explored how that financial extraction, the sale-leasebacks, the margin filtering, the upselling is being fatally compounded by the biological ticking clock of antimicrobial resistance.
When superbugs render basic antibiotics useless, routine infections become prolonged, agonizing ICU stays, creating the perfect storm for total medical bankruptcy.
We've seen how the populations most vital to the nation's survival, the farmers and manual laborers, are the most exposed to the pathogens and the most completely priced out of the cure.
And we've detailed how highly scalable, decentralized solutions, like the Prima kiosk, capable of bypassing this trap, are actively stonewalled by the very institutions that profit from the crisis.
It is a dense, challenging analysis of how deeply interconnected capital, biology, and bureaucracy truly are.
We want to thank you for joining us on this deep dive. We highly encourage you to seek out the provided sources, to look at the Graham Project data, and to read Dr. Srivatsa's policy brief for yourself to see the raw arguments firsthand.
Understanding these dynamics is absolutely vital for anyone looking at the future of global health infrastructure, because the economic and biological pressures described here are not contained by national borders.
Definitely not.
We want to leave you with a final thought to mull over, building on the realities we've uncovered today. We've explored how modern financial structures view human health as an asset class to be mined for maximum margin.
Right.
But as we accelerate toward that 2035 collapse point, the era when the frontline drugs completely fail and routine everyday infections become lethal threats, the entire social contract shifts.
It really does.
What happens to a national economy when its foundational workforce, the people growing the food and building the infrastructure, realize that simply stepping outside, getting a minor scrape on a tool, or catching a seasonal fever isn't just an inconvenience?
When they realize it is a mathematically guaranteed path to permanent financial ruin or death.
Exactly. Are we currently witnessing the final days of healthcare as a fundamental human service and quietly entering an era where basic biological survival becomes a luxury commodity available only to those who can afford the highest margin? Think about that. Until next time.